On-the-scene coverage of ACC 2015 is supported by Effian.
I'm Peter Block in San Diego for ACC 2015. I'm here for On the Scene, and with me is Christina Angermann from Germany. So she has just been reporting on the MOOD-HF trial, a heart failure trial trying to determine whether or not treatment of MOOD makes a difference. So tell me what the trial was all about to start with, and then we'll go into what you found.
MOOD-HF is indeed the first randomized controlled trial of at least moderate size, which addresses the question whether treatment with an antidepressant, in this case the SSRI escitalopram, in depressed heart failure patients would improve heart clinical outcomes as mortality and morbidity aside of mood in this population.
So in fact it is a randomized trial.
It is a randomized controlled trial performed in 16 German academic centers who feature both particular experience in heart failure as well as psychiatry.
So there is a fair amount of background information about mood and heart failure, depression and heart failure. So this sort of sits up on top of those data, or is this a different kind of trial?
Well, this does not sit on top. However, the fact that depression is about 3 to 5 times more common in heart failure compared with the general population is of course a background, because we know that depression in this patient population is associated with adverse outcome. We have recently been able to show, by the way, that there is even a dose-response relationship between the severity of depression and morbidity and mortality risk in this population. And of course, improving depression might, and this is the concept, also improve in the long run if we wait long enough and treat well depression, not only depression, but also morbidity and mortality.
Okay, so you randomized these folks, treated half of them, didn't treat the other. What did you find?
Well, we found that an antidepressant applied in a heart failure patient with comorbid depression does neither improve depression nor outcomes, mortality and morbidity. That was our combined primary endpoint. And so a lot of heart failure patients nowadays treated with an antidepressant, preferably an SSRI, are treated probably in vain. Although we found some peculiarities in subgroups, that patients who were elderly, who were sicker in terms of having higher NT-proBNP values, low ejection fraction, more symptoms in terms of New York Heart Association functional class, and also a higher heart rate. They had a trend towards an adverse effect of escitalopram. And when we then were tempted to generate a post hoc risk score based on these subgroups, we found indeed that there were patients scoring low, having a small number of these risk factors. They fared better on escitalopram. However, those that scored 3 or 5 to 5, they fared worse, indicating that the disease profile of heart failure may perhaps critically modulate the response to an antidepressant like escitalopram.
So there we have a randomized trial, first one actually, for patients with heart failure and depression. Primary endpoint is a negative endpoint, or at least no positive endpoint there, but some interesting issues about subgroup analyses. Thank you.